Podcast 9 of the Thorax series, the autonomic and somatic nerves of the thorax. This podcast is going to detail both the autonomic and somatic nerves of the thorax, and also detail referred pain using some common examples. The thoracic viscera, which consists of three systems, the respiratory, the cardiovascular and the digestive, all receive inputs from the autonomic nervous system to control the level of their activity. The surrounding body wall of ribs, muscles and skin receives somatic innervation via spinal nerves, and these control the muscular contractions and sensory inputs. So here, one region of the body is supplied by the two main functional divisions of the nervous system, the autonomic and somatic divisions. Now, before we go into the precise details of how these systems relate to the thorax and its viscera, we need to remember the key differences between these two systems. So the somatic nervous system is involved in both the motor and sensory innervations of the body wall, and that includes innervating muscles for contraction and also receiving sensory inputs from the skin or from stretch receptors in muscles. This information reaches the conscious level, and therefore we have a certain amount of conscious control over it. The individual motor neurons that carry motor information away from the spinal cord towards the muscles, and the individual sensory neurons that receive sensory information and take it towards the spinal cord, are all bundled together into a spinal nerve, much like the individual wires in a telephone cable, with each wire carrying a specific piece of information. Now, much like an earthworm, the spinal cord is segmented, and it contains 31 individual segments. Now, each of these segments gives rise to a left and right spinal nerve, and these spinal nerves can be grouped into specific regions depending on the location that they leave the spinal cord from. So the spinal cord's 31 segments are divided into a cervical region, which comprises the superior 8 segments, and we therefore have 8 cervical spinal nerves, C1 through to C8. And then we have 12 thoracic segments, so T1 through to T12. We have 5 lumbar segments, 5 sacral segments, and 1 coccygeal spinal segment. For the somatic supply of the thorax, we are only going to focus on 2 of these regions. A nerve which is derived from the 3rd, 4th and 5th cervical spinal nerves, and the 12 thoracic spinal nerves, and let's start with these. So the 12 spinal nerves that originate from the thoracic region of the spinal cord are collectively known as intercostal nerves, although the 12th intercostal nerve is strictly known as the subcostal nerve, as it runs inferior to the 12th rib. As you are probably aware by now, if you have listened to all the podcasts in this series, then the paired intercostal nerves that leave the spinal cord run along the inferior border of the ribs in the costal groove, and they supply the contents of each intercostal space. They also supply the skin which surrounds the intercostal space, and also the parietal pleura that lines the inside of the thoracic wall, specifically the costal, cervical and peripheral diaphragmatic parietal pleura. So the intercostal nerves, which are somatic nerves, contain motor and sensory neurons and supply the muscles in the intercostal space, the surrounding skin and parts of the parietal pleura. Because each of the intercostal nerves that run against the rib also supplies the skin associated with the intercostal space, the sensory map of the thorax is banded and resembles a hooped jumper with a series of horizontal bands running around it, with each intercostal nerve supplying a specific hoop. The other somatic nerve that is involved in supplying somatic innervation to the thorax is the phrenic nerve. The phrenic nerve is like all somatic nerves and is comprised of both sensory and motor parts. Its sensory neurons receive sensory inputs from the mediastinal and central diaphragmatic parts of the parietal pleura. Its motor neurons control the contraction and relaxation of the diaphragm. So the phrenic nerve is an important nerve of respiration, and we again have control over it. However, the phrenic nerve is slightly different, because although we have control over its ability to contract the diaphragm, we do not always consciously do this. For example, if you want to, you can take a deep breath by consciously contracting your diaphragm, but we don't always have to remember to contract our diaphragm to breathe. Most of the time, we do it automatically without realizing, especially when we're asleep. So how does the phrenic nerve know to cyclically contract and keep us breathing? Well, the C3, C4, C5 cervical spinal nerves, which form the phrenic nerve, originate from the phrenic nucleus, and this contains the cell bodies of the motor neurons that are supplying the diaphragm. This nucleus receives inputs from the respiratory centres, which are located in the medulla of the brainstem, and this controls the cyclical activity of the phrenic nerve, causing the repetitive contraction and relaxation of the diaphragm. Okay, so if we now turn to the specific autonomic distribution to the thorax, then again we'll briefly review the major features of the autonomic nervous system. So if we remember that the spinal cord is divided into various regions, then coming from the brainstem and also the sacral regions are autonomic nerves, which are parasympathetic in nature. Autonomic neurons derived from the thoracic and lumbar regions of the spinal cord are going to be sympathetic in nature. So the craniosacral outflow is parasympathetic and the thoracolumbar outflow is sympathetic. The sympathetic neurons that leave the thoracolumbar regions form the sympathetic trunks that run either side of the vertebral column, and from here give off sympathetic nerves that are involved in controlling the thoracic viscera. The sympathetic trunks that run up and down the vertebral column is a collection of what are known as paravertebral ganglia, and these are joined by connecting branches to form the sympathetic trunks. You shouldn't let this description confuse you. Remember, a ganglia is just a collection of neuronal cell bodies, and paravertebral means that these ganglia lie parallel to the vertebral column. So a series of ganglia running parallel to the vertebral column are the paravertebral ganglia, and these join together and form the sympathetic trunk. Each system found within the thorax, so the digestive system, the respiratory system, and the cardiovascular system, each has a plexus of autonomic nerves associated with it: the esophageal plexus, the pulmonary plexus, and the cardiac plexus, with each of these receiving both sympathetic and parasympathetic inputs. So if we consider the pulmonary plexus first, then this collection of autonomic nerves are positioned anterior and posterior to the lung roots, and receive parasympathetic inputs from the two vagus nerves. The pulmonary plexus receives its sympathetic innervation via the pulmonary splanchnic nerves, which are derived from the T1 to T5 ganglia of the sympathetic trunk. This precise description of the sympathetic input is important when we consider referred pain later in this podcast. The effects of the autonomic nerves on the thoracic viscera are predictable if you consider the sympathetic division to be involved in the fight or flight response, and the parasympathetic division involved in the rest and digest response. For example, during periods of sporting activity, the sympathetic fibres within the pulmonary plexus will cause bronchodilation to increase airflow to the lungs, and vasoconstriction of the pulmonary vessels, which will increase the blood pressure and therefore increase gaseous exchange. Conversely, during periods of rest, the sympathetic nervous system will no longer promote bronchodilation or vasoconstriction, and the parasympathetic division will cause bronchoconstriction and vasodilation, resulting in a lower level of gaseous exchange. So now let's turn to the cardiac plexus. The cardiac plexus is formed in a similar way to the pulmonary plexus. This plexus is divided into the superficial and deep portions, which are located posterior to the left atria. From here, the plexus gives off its autonomic branches to the coronary arteries and the sinoatrial node. The cardiac plexus receives parasympathetic inputs via the vagus nerve and its sympathetic inputs is via the cardiopulmonary splanchnic nerves, which come from the T1 to T5 ganglia of the sympathetic trunk. Again, this precise description is important when we consider referred pain. So what effects do the autonomic inputs have on the activity of the heart? So the sympathetic nervous system is going to increase the rate of sinoatrial node depolarization, which will increase atrial and then ventricular contraction, and this will cause an increase in the heart rate, the stroke volume, and therefore the cardiac output. For the myocardium to meet the demands required for the increased level of activity, the sympathetic nervous system will also cause the coronary arteries to dilate, allowing more nutrient-rich, oxygenated blood to supply the muscles. Removal of this input or activation of the parasympathetic division will cause the opposite effect. Cardiac output will drop and the coronary arteries will narrow. The final plexus of autonomic nerves that I will consider is the esophageal plexus. This plexus is formed by the left and right vagus nerves and also some esophageal splanchnic nerves, which are derived from the T4 to T6 ganglia of the sympathetic trunk. Again, the functional effect of the autonomic distribution on the esophagus is fairly predictable. Sympathetic inputs will prevent both esophageal secretions and peristalsis, whilst parasympathetic inputs will increase both the esophageal secretions and peristalsis. So to finish the podcast, that I want to detail referred pain within the thorax. So referred pain is the feeling of pain from a different location to the source or the origin of the pain. Common examples are the feeling of pain over the left upper limb and chest region during a heart attack, or diaphragm irritation, which is felt over the shoulder. So what is the mechanism of referred pain? In order to fully understand referred pain, you need to have a good understanding of both the autonomic and the somatic nervous systems, as referred pain utilizes components from both of these. Like I described previously, each organ within the thorax receives an autonomic supply via either the vagus nerves or the sympathetic splanchnic nerves, while alongside these inputs which control the level of activity of that organ, the thoracic viscera also gives off autonomic sensory nerves, sometimes referred to as visceral afferents. These visceral afferents, or autonomic sensory nerves, take information towards the spinal cord regarding the condition of the organ, like levels of organ distension or the blood gas levels. But unlike the somatic sensory fibres, we are unaware of these visceral autonomic nerves. We do not consciously feel them. So let's consider a heart attack. I'm sure you're aware that people suffering from a heart attack usually feel pain down their left side. So how does this work? When the heart becomes ischemic due to the lack of oxygen required to maintain the heart rate, then the accumulation of metabolic byproducts stimulate these visceral afferent or autonomic sensory fibres in the myocardium. This information is sent back to the spinal cord as pain, and it runs alongside the sympathetic cardiopulmonary splanchnic nerves that were running towards the heart. This is why we need a good understanding of the spinal cord level which the sympathetic nerves are derived from. So visceral afferent fibres transmit sensory information back to the spinal cord from the organ along the same path that the sympathetic inputs travel. So how does this pain become referred to the left upper limb and chest region? Well, now you need to remember that the cardiopulmonary splanchnic nerves that supplied the heart were derived from the T1 to T5 spinal cord level, and appreciate that the visceral afferent fibres that are returning to the spinal cord are poorly localized. This means that the spinal cord and brain are not aware of their location. They are not aware that they are coming from the heart. So the body interprets this pain to be coming from the region of the body wall which is applied by the somatic spinal nerves of the T1 to T5 segments. As the somatic spinal nerves from the T1 to T5 region of the spinal cord supply the upper chest and parts of the left upper limb, this pain is referred to this region. So the visceral afferent fibres return this visceral sensory information to the spinal cord, and the brain interprets this information as coming from the body wall, which is supplied by the somatic sensory nerves that also enter the spinal cord at this level. So in order to understand the distribution of referred pain, you need to know two things: the level of the spinal cord that the sympathetic autonomic fibres enter into, and then the body region which the somatic spinal nerves originating from these spinal cord segments supply. So finally in this podcast, I just want to detail some referred pain that does not involve the autonomic nervous system and is associated with just the somatic nervous system. For example, the diaphragm and the parietal pleura that covers its superior surface. If they become irritated, then the pain is going to be perceived or referred to the sensory distribution of the nerves that supply the diaphragm. Now we already know that the diaphragm is supplied by the phrenic nerve, and we also know that the phrenic nerve leaves the spinal cord at the C3, C4 and C5 region. We also know by using the dermatomal map of the body that the C3, C4 and C5 segments supply sensory information to the shoulder. So if the central part of the diaphragm's parietal pleura becomes irritated, the pain is going to be referred to this region. So in this podcast, I've detailed both the autonomic and the somatic nerves of the thorax, and also detailed referred pain. In the next podcast, number 10, I'm going to look at some clinical considerations.